My name is John Gordan. I am Senior Vice President of Innovation at Commonwealth Care Alliance and Managing Director of Winter Street Ventures, our captive venture investment subsidiary. CCA is a 40,000 member dual eligible plan based in the state of Massachusetts. Our focus is on managing the needs of high need, high risk individuals, all of whom are both Medicare and Medicaid eligible. They have often typically high numbers of chronic conditions. 1/3 of our population is over the age of 65 and qualifies for Medicaid as well. The other 2/3 actually is under 65, but would either have severe mental illness or neurodegenerative disease. Innovation is a really interesting thing in healthcare because it's one thing to innovate in consumer electronics, for instance. If you try an innovation in healthcare and it doesn't work, there are actually people's lives at stake. And so healthcare by its nature is a conservative industry. So innovation is naturally, in healthcare, is naturally about balancing the needs of the healthcare industry to continue to deliver greater value, be more efficient and more effective, at the same time while being cautious about the real impact that we can have on people's lives, both positive and negative. The way I look at innovation in healthcare is you have the care delivery itself, and then you have everything else that supports the ability to deliver care. And unfortunately, a lot of what's happened over decades of running a fee-for-service healthcare system overall in this country, is that we've layered on a whole lot of sort of operational needs and bureaucracy that go along with that, everything from risk coding to claim submission and so on and so forth. And so there's all of those pieces, whether it's thinking about how do we deliver care differently, and to, the last 8 months or so with the explosion in telehealth is a great example of, rapid cycle evaluation forced by a very significant need, where institutions that were saying, we can't deliver care virtually, or we're not ready for that sort of thing, were forced to adapt and quickly take on new means of communicating with their patients. And it turns out the result in that case, a lot of people went, wow, that was actually way better or way easier than I thought. And that's on the care delivery side, or it could be different models of care themselves. And on the other side, it could be, it could be things like one step back, which is leveraging artificial intelligence and, sensor networks and things like that to collect information, to actually do innovative predictive models so we can actually intervene and really focus on going from a sick care system, which is truly what we are, to a healthcare system where we're managing people's health as opposed to responding to their sickness, to, a couple steps down that line, that value chain, which is, it could be just better ways of doing claims processing. It could even be better ways of doing accounts payable, just reviewing accounts payable invoices. At my previous employer, we brought in robotic process automation and just automated the process of just paying bills that came in the door. And that saved us millions of dollars a year. So there's, healthcare is, 1/6 headed towards 1/5 of the US economy. And there's all kinds of places to work. And I think anywhere we can be more efficient, more effective, deliver a better result for patients. And that's better care, not only better care, but also it's about making the processes that the patient experiences better. The example of CCA is a very illustrative one. Our care model, given the complexity of our patients, our members that we talked about, is very much home-based. And something like 72% of our over 65 population is nursing home eligible, but only 5% of them actually are in a facility. And we do that because we spend a lot of time in the home. And obviously COVID meant that we were not spending a lot of time in the home. And the first reaction was, oh my gosh, our care model is based on being in the home. How are we going to stay in touch with our members? And so what we shifted to is this virtual care model of leveraging telehealth to create the touches with the members that need that interaction. But we also just honestly made a lot of phone calls. We did almost 1 million phone calls to our 40,000. That's 25 phone calls per member. So like at least a call a week just to check in on them and say, do you have enough food? Do you have enough, do you have the services that are coming to you? Do you have all your medications? COVID is an example of how it gives us an opportunity to kind of reset and rethink sort of things that we had taken as the status quo, whether it's virtual care, and we thought we were going to do a small amount of virtual care, knowing that making the assumption that a duals population isn't particularly technology savvy. And now we expect that, a quarter to a third of our care going forward will be delivered electronically or virtually in some form. It gave us the opportunity to rethink those assumptions.